Assistants aren't allowed to do any kind of assessment or anything like that. All right, so that is the big difference. All right. In the area where I work, just because our volume is so high, I am doing mostly evaluations and reevaluations, and our PT assistant is doing a lot of the treatment sessions. So in this case, will be follow-up maybe 1 or 2 more times for a typical person that I would work with. Okay.
Yeah. Do you know if the PT assistant programs, are those 2-year programs?
Yes. So PT assistant program you can take through like Pitt Community College. It's an I think it's an associate's degree, and it is a 2-year program. That's right. You don't have to have a bachelor's for that. Okay. So another thing that I have to do, after you get your license, is you have to maintain your license through continuing education. So one way to do that is to work on getting a specialty, because you're going to be doing a lot of continued education for that. And basically what I have to do is every couple years or so, I have to put in, this information on certain things that I've done to show them that I'm still keeping up with all of the new information, because there's constantly research going on, and things are just constantly changing. So I need to be able to show that I'm still competent to work with these patients. Okay, and if you get your license lapsed, then you have to pay a lot of money and then do all these courses anyway. So you definitely you always want to keep up with that. Mine are due this December, and I have not kept very good track, but that's a different story. I'll be okay. All right, so let's talk about a little bit of the day-to-day with what I do. All right, so again, I work in the heart center, so I come into the hospital in the morning. I go up to, we have a physical therapy gym on the 4th floor, and we treat patients in there. A lot of times, I start out by treating patients in their room. Okay, we cover three different floors. We have 2 ICUs and 2 intermediate units. I don't know why they call it an intermediate unit, because it's not like there's anything below the intermediate. It's like ICU, intermediate, and then wherever else you go, home or whatever. In the heart center, there is also the orthopedics floor. That's on the 6th floor. Again, that's where I work with the athletes or people who hip replacements, knee replacements, back surgery. Anyway. I stay busy enough that I don't really do a whole lot of the 6th floor orthopedics. Again, because like I said, we have 3 people covering 3 floors. I work mainly in the surgical ICU, so these are going to be patients after usually an open heart surgery. At the hospital, we also do some minimally invasive heart surgeries, which is pretty cool. And then we actually have a new procedure, a new very, very minimally invasive valve replacement surgery that is kind of making our hospital a pretty big deal right now, because there really are only a couple places in the country doing this type of surgery right now. So I work a lot with those patients. I would work with patients that have congestive heart failure and they're in the hospital because maybe they can't afford their medications or they're not taking their medications. Again, I work with patients that have had amputations, vascular surgeries, lung surgery. So I come in the morning, I look at the list of patients that we have, I figure out who I'm going to see. I work with a lot of patients that are critically ill. We have patients that I work with that are on the ventilator, but they actually make portable ventilators so we can walk patients on the ventilator, which is pretty neat. Another thing that's really common after any kind of surgery is a stroke. Anytime you have a surgery, the chance of having a stroke after surgery, depending on your age, can be pretty high. So let me paint a picture of a patient that I may see in a typical week. All right, so this patient has open heart surgery. So for the next 6 to 8 weeks, this patient can't use their arms to help them stand up, sit up from lying down. They can't pick up anything heavy because they have to let the bone heal, okay? So now imagine they have these restrictions and then they have a stroke and one side of their body is now flaccid. So they have one extremity that they can use to help mobilize them, all right? So a lot of problem solving involved with that. I start out just seeing what we're able to do. If the first day I work with someone, if the only thing we can do is sit up on the edge of the bed, then sometimes that's a lot because they could be on the ventilator and have 1,500 tubes lined with drains all over the place. Probably one of the most challenging patients that I work with had an open heart surgery, and then after the surgery the patient had a severe blood clot and they had to amputate both of the patient's legs above the knee. So I had a patient with no legs who could not use their arms to help with anything. And that was actually my first day working completely by myself, and I was a wreck. But I ended up calling in reinforcements. I didn't even cry much. But that one was challenging. But that patient ended up walking again. They ended up getting prosthetics for both sides and ended up coming back in to see us. So very, very rewarding work. Very challenging, but very rewarding. I want to show you some pictures. So I want to show you some of the stuff, some of the equipment that I work with on a day-to-day basis, and I brought in a couple things that you can kind of see as well. So let me show these to you first. Okay. I use this with most of the patients that I work with. It's called a gait belt, G-A-I-T. Okay. This just goes around the patient. Right. This one obviously is a large size. But I tell you what, especially in eastern North Carolina, the diabetes belt of the country, almost, there's not a whole lot more embarrassing than walking into a room with a very, very large patient and an itty bitty belt. So this just goes through here like this, like this, here's up tail. Okay. This gives me something to hold on to. Now obviously this is way too loose. If somebody tried to pick me up by this, it would really hurt. Okay, so we snug this up. So now, especially with my patients who've had heart surgery, all right, who you really shouldn't be pulling on their arms or anything, okay, or a patient who's had a stroke who's at risk for having their shoulder dislocate anyway, this gives me something to hold on to, all right? These help prevent falls. I had a patient that fell the other day just because stuff happens, and we held on to the belt, and the patient was fine, which was a little scary because they were on the steps, so. This is probably my favorite tool. I very rarely work with patients without this or something similar. I've worked with patients before who had open heart surgery and then had to have abdominal surgery, so they had an incision all the way up and down. So something like this would probably not be very comfortable, but you need something. So I'll take a sheet and tie it around there, all right? Kind of disperse those forces a little bit more than this little skinny belt. Alright, anybody ever seen one of these before? Yeah? You know what it's called? No? It's called a Hemi walker. This is a great device for a patient who has had a stroke, right? Not necessarily a patient with the sternal precautions, alright, because you have to push down on this, alright? But you see how it's got this really wide base here? A lot of times after having a stroke, these patients are going to have some pretty big balance issues depending on where their stroke was, alright? So, they would hold this in one hand, and this is very, very stable, alright? Especially if the left side of my body is either flaccid or very, very weak. It may be really hard for me to use a walker. Sometimes after a stroke, you can have different types of problems. All right, you can have problems where you are flaccid. All right, so your muscles are not getting the signal from your brain that they need. But in some cases, they're getting too much signal from the brain, so they have what we call increased tone. So they wouldn't be able to use a walker because their arm is kind of stuck out like this anytime they try to do anything with it. So in that case, one of these would be really great, all right, because this is very stable. Can be a little bit cumbersome. Actually, I've already kicked it like 3 times just walking with it now, all right? And this is great. The tool that I use the most, and I'm sure everybody has seen one of these, is a rolling walker. All right. Now this has a platform attachment on it. That just comes on and off. All right, I just put it on there for now for ease of transport. But the ones with the wheels on is great because you just scoot it right along. We can use these with our sternal precautions patients because they're not pushing down on it really hard. They're just kind of holding on to it. Because when you fall, the first thing that you're going to do is throw those arms out. All right, and with a sternum that's healing, that's not very good news. All right, so, say you do have a patient who had a stroke and they're very, very weak on one side and they can't hold on to the walker, all right? That's what this is for. It's a platform attachment, all right? It's adjustable. I can put it on either side and rotate things, okay? Bring it up and down. It's got a strap here, if the patient doesn't have the grip strength to really be able to keep that in there. So, just kind of like this. Bam. This part rotates as well. And then I can actually put some weight through my arm here to stabilize. My walker is old as dirt, so it doesn't steer very well. But all right. You might know what this is? Any guesses what you'd use it for? Perfect, right. This is called a sliding board. All right. This is something that we used with our patient who was amputated on both legs, but they had to have a lot of help because they weren't able to use their arms on this. This is something you could see for a patient who has a spinal cord injury, all right? Or a stroke if they don't have the strength to stand. So you use this to kind of make a bridge between your chair or your wheelchair, all right, and the surface that you're going to. It's got handles on it, but you don't ever want to put your fingers in those handles, all right? Just pick it up with, because if you put your fingers down like that and then put body weight on, it's not going to feel very good. And then it is also angled, all right, so you can kind of slide up and down it. A lot of times what I'll do is I will also put a pillowcase on this, and that makes it a lot easier for the patient to slide across it, because your bare skin will kind of stick to this a little bit, whereas the pillowcase will slide very easily. So those are just a couple things. Let me show you some pictures of some of the other things that we use. Okay, this is a fantastic machine. It's called the Moveo. That's actually my student. We faked an injury for her, just so I could kind of show you what this does. It's a mix between a tilt table, so you can see I have it tilted up to, I think it's about 30 degrees, and you can also do a leg press. The thing that she sits on slides up and down. So the higher angle you have, the more of a workout your patient is going to have. Now the way that I have it set up is someone who maybe has an injury on this side and isn't allowed to put weight through that leg, okay? It's got foot plates that come up and down, and this is actually an attachment, all right? This is also great for patients after an amputation, like a below-knee amputation. I use this machine a lot for those patients so that they can strengthen the other side, because they're not going to be getting a prosthesis right away. So the other side needs to be really strong first. This machine is also great for patients that have been in the ICU for a long time. I have a patient that I'm working with currently who had surgery well over a month ago and has been very, very sick since then and is not strong enough to stand yet. So what we can do is I can put this down flat, transfer the patient over, and work on some leg exercises. So not only are we getting the strength, we're building that endurance back up too. Endurance, that's going to be the first thing to go. If you think about any time you've ever had the flu or something like that, so you're in bed for 2 days, when you try to get up, you almost fall onto the floor. All right, imagine that times like 10, okay? So this machine really is fantastic. We've had it, I think probably not even for a year. I'm a big fan. There's a lot of things that you can do. You can work on doing weights, okay? You see this little black bar going all the way around? You can put some resistance band on there, okay? It's kind of like a giant rubber band. I meant to bring some with me and I forgot. I'm sorry. To work on arm stuff. Unless your patient has sternal precautions. So, we don't always do a whole lot of that. Okay. Another thing I can do is when my patient is using this, I can give her feedback, just that little tactile cue there, all right? Sometimes you'll see patients when they're coming down, that knees wobbling back and forth, it's because they don't have very good control of the muscle. So that may mean that we need to adjust this angle a little bit, because if it's too high, you know, you kind of burn them out really soon, and that's not very good workout. All right. Stair training. I do a lot of this, especially with our patients that have had some kind of vascular surgery. If they're not allowed to put weight on a leg and they have to get up and down steps at home. So this is going to be stair training on crutches. So I do that a lot. This is pretty neat. This is something that is relatively new to our floor, and this actually is in our therapy gym on our 4th floor. It's called a cardiac walker. This one specifically is. Another term is a platform walker. So this is a rolling walker with a platform attachment, and this can also be called a platform walker. Okay. This is good. I use this a lot with vascular patients. I have a little bit of a debate with my supervisor about whether this is appropriate or not for cardiac patients, because I still think they're pushing down. But anyway, so this is a great tool. The oxygen tank holder is my favorite part, because we do have to have oxygen in some kind of holder. You can kind of see one in the background there. It's just a little cart with wheels on it. So if you have to hold that and an IV pole, well then who's holding the patient? So I've worked with patients before that have so many tubes, lines, and drains, they need one person to work with the patient and 2 more people to deal with all the tubes, lines, and drains. That's happened on more than one occasion. So this is a good example. You could use this also with a patient who's had a stroke or something like that, because this allows me to get into a very good position, because sometimes people will lose a lot of strength in their leg and not really be able to advance that leg very well. So as the therapist, I actually can kind of squat down and I can actually help that patient move their leg forward. So that's one of the advantages of this, whereas the walker, you know, it's got all this stuff on the side in the way. So that makes it very difficult for me to be able to do that using this type of walker. Okay, this is an example of a sliding board transfer. So the patient's on the mat table, they place the sliding board and then underneath of them and then onto the wheelchair. I help her kind of scoot over and then we pull the sliding board out. It usually does not go that easily. If it does, they probably don't need me very much. This is an example of a squat pivot transfer. All right, so this is where the patient is probably not necessarily strong enough to stand all the way up to turn and sit down. So what we're doing is the patient is kind of squatting, all right, and turning, and I'm helping her get from the chair to the mat table. I tried to do a picture for the stand turn transfers, but it didn't turn out very well. So maybe next time. We also have some equipment that we can do for shoulder exercises. This is called a restorator, kind of like if you've ever had a shoulder injury and you're at your outpatient PT, they'll start you out with a warm-up exercise on some kind of arm bike. So that's what this is. And I can kind of position myself so I can give her some feedback so she's not overutilizing one muscle or another. This is a tub transfer bench. This is some of the equipment that is available for patients. So you have a patient who's in a wheelchair and they need to get in and out of their bathtub. All right, this is going to sit on the outside of the bathtub so they can transfer onto that and then scoot across so they can actually sit on the other part in the shower. So that's pretty neat. Okay, this it's called a zero gravity. This is something that they have down in the neuro rehab gym. This thing is attached to the ceiling, probably close to the size of this room, and kind of makes a like a U shape, all right, all the way around. It's like a body weight support system. So the patient is in a harness, and this thing actually raises up and down. You can see a little rope thing that they use, and they can help with helping that patient walk. They can also work on other positioning with this, whether that's getting onto all fours and working on balance activities, and just having that little bit of extra support. Okay, this is really cool. This is that new piece of equipment that they have in inpatient rehab. That's really neat. I don't work with patients on this because I'm not an inpatient rehab therapist, and a lot of my patients can't use this anyway because if you have a history of severe cardiovascular issues, then you can't use this. So there goes my entire population. This is great for patients that have had like a spinal cord injury or a stroke, just to name a couple. What this is it's a robot. You get strapped into this robot, and this is a treadmill, and this robot helps you learn how to walk again. So this is a big deal that we were able to get one of these. I have a video, and I hope that it works. It didn't work earlier, but I'll give it a try. All right, so these are just a couple pictures. So this is from the front, so your patient would be here facing you. This would be at about where the hip would be, okay? And then it straps into the legs. This is a side view, okay? So all of these strap into your legs, all right? And then this is a side view just because the thing was moving when I was taking pictures. Okay, so this would be the view from the back of the machine. So say your patient is here, and they are in a harness, right? They're going to be hooked in, okay? They're going to be on the treadmill. They have a screen here, and in this, there's a little avatar guy who's actually walking, and the terrain in the picture changes, so that's kind of neat. I think that they have a lot of other stuff that they can do on the screen. And then this is just the control panel for the Locomat. I'm not trained on the Locomat, so I can't tell you what any of that stuff does, but it looks important. Glenn Newman is trained to use the Locomat. He's the one that I said that you could contact if you were interested in shadowing. Like I said, this really is a fantastic piece of equipment that costs more than I will make in a lifetime. All right, let me see if my video is going to work. Maybe. I'm going to turn the sound down because it's just me talking. Alright, so the treadmill down here is moving. And you can set this for, it's got different settings. Alright, so the patient can be doing more or the patient can be doing less. You can set it so the patient is completely moving one side on their own and the robot is helping with the other side. Oh, I'm so glad this worked. It's really neat. Very, very cool. If you're a PT nerd. And that's I think that's about it. Do you guys have any questions about anything?
I do. How far in advance before graduation should you look into applying? Because I know I'm graduating next May, so I was looking into taking the GRE in the fall.
Okay.
Is that like enough time? Because I want to go straight into grad school for PT.
Yeah, and that is something similar to what I did. In hindsight, I probably would have taken the GRE a little bit sooner, just in case my scores weren't what they wanted them to be, but my scores were okay. But they do have like an early application program, and I think that your application would have to be in at the fall, and I think that they interview in December. I'm trying to remember. And then the normal application process is going to be in the early spring, and they interview in March, something like that. But I took a similar course, but I probably, like I said, I probably would have taken the GRE again if I
And I would stick in there that the applications, I mean, if you're thinking about it, if you want to go straight through, then you've got to have everything ready and applying in the fall of your senior year. So if you want practice time, if you want to leave room to take 2 GREs, perhaps even stick a few months in between your 2 attempts, because it's really not a test where you come back 30 days later and do better. I mean, it really isn't. So, I mean, kind of, you know, that towards the end of junior year and into that senior year is probably the ideal time to look at it if you're wanting to go straight through.
And make sure that you have all your classes, because my last semester was a complete disaster. I found out, like I had my GRE done, I had all my shadowing time done. My last semester, after I started my internship, I found out that I was short by class. And so my last semester I was taking 22 credit hours. I was doing a full-time internship, working, taking this extra class, and then I had to work out something special with the department head of the class that I was missing. I'm like a poster child for what not to do. And I was like, oh, if I can handle this, the PT school is going to be easy. And I was completely wrong, because it was very hard. But, so.
Are internship hours not considered the hours that you need for shadowing?
No.
No. So you need
Unless it's directly with a physical therapist. The shadowing hours
yeah,
have to be. Okay. But another thing that does look very good on a PT school application is not necessarily just doing all your shadowing hours in one setting. Doing hours across different settings is going to look very good.
That was my question, like what kind of places did you do your volunteering shadowing at?
I did all of my hours in outpatient. Again, if I could go back and do it differently, I would have split it up between acute inpatient rehab, you know, outpatient. Again, there are several skilled facilities in Greenville, and that is going to look very good on your application if you have a lot of hours in various different settings, because, you know, you're a little more well-rounded that way. You know, you have more experience in more than one different area. So.
And when did you start like doing your shadowing time? Like after freshman year? Or
Yeah.
Right after that summer?
I started after my sophomore year. I did most of mine all at one time, and then I was kind of just doing them in the summer in between working. But I mean, if you want to do 500 hours, that's going to look fantastic. All right, the 100 is a minimum. But yeah, I recommend, you know, splitting up.
What kind of place, like I'm a freshman, so what kind of place should I could look for to do like this summer?
This summer, well, again, you can contact if you are interested in more of what we do at the hospital, because there you really could do 2 different settings. You could do an acute and you could do inpatient rehab. So you'd have hours in acute and hours in inpatient rehab, which would look really good. So if you do want to contact Glenn, there are also several outpatient physical therapy places in Greenville.
I'm not, because I won't be here this summer. So.
Oh, okay. Well, pretty much any hospital in any city is going to have physical therapists. So if they have like a volunteer program at that hospital, I would contact that department to start out with, and they'll be able to get you to the right people. Otherwise, you know, you can do the way that I found the outpatient place where I did my shadowing. I went on Google and looked up outpatient PT in Winston-Salem, because that's where I did mine. So that's an easy way to find outpatient. And a lot of times they're very willing to have students help, because I mean, I got to work with patients. I wasn't assessing or doing anything like that, but I was learning about exercises, and I was able to really help out. So it was a great experience for me.
Yeah, and we suggest networking as well. I mean, if you know someone who works at the hospital, that might, you know, be an easier in. If you know, uncle's a physician, works around PT, something like that. So just sort of starting that sooner rather than later is a really good idea. And you're right, I mean, fitting that experience in wherever you can, like what you said, as far as, I mean, when you think about, you have 3 weeks in December where you can really get a lot done, using that time where, you know, so then you're not bogged down trying to do like 15 or 20 hours a week, you know, during the semester when you're heavy with class load.
At the hospital, we do also in acute care. We work on weekends. I work a weekend every 4 weeks. I'm actually working this weekend. And at first it kind of sounds like, oh, what a bummer, but I actually really like it because I get a day off before and after, so if I need to like make a doctor's appointment, I don't have to schedule time out of work. I can just arrange it around that. So if you're interested in, picking up a couple hours on a weekend here or there, you could come in an afternoon